Good evening, respected faculties, all the member and all the participants, those who have joined us in today's webinar, Searchlight 24, through this Zoom link and on our Core Connect platform as well. Today's topic is on Late FGR in association with Bhimavaram, Moradabad, Muzaffarnagar, Mysore, Nadiad, Nagaon, Jaunpur, Jalgaon, Mehsana, OBS and Gynae Society, and Society of Fetal Medicine, Chhattisgarh. To start today's program, let's take the blessing of the divine.
वक्रतुंड महाकाय सूर्यकोटि समप्रभा निर्विघ्नं कुरु मे देवा सर्वकार्येषु सर्वदा
Let me introduce the conveners of today's program, Dr. Sujayasri Sangeeta. She is present appointed consultant obstetric and laparoscopic surgeon, Shashadri Hospital, Palakol, Malikapuram. She is founder secretary, Bhimavaram OBS and Gynae Society. A very warm welcome, ma'am. Another one is Dr. Purvi Agrawal. She is MBBS DGO. She is director and consultant fetal medicine at Krishna Fetal Medicine Center, Raipur. She is executive member SFM Chhattisgarh, past IFS executive member, IOTA FMM certified. She is a well-known personality, and for further proceedings, I'd like to invite her on the dais, and I'd like to transfer the session to her to please proceed forward. Thank you so much, ma'am. A very warm welcome.
Thank you. Good evening, everyone. I am Dr. Purvi Agarwal. I'll be the convener of this session. First and foremost, I would like to welcome our mentor program director, Dr. Asha Jain, ma'am.
Piyush, you need to share my CV.
Ma'am needs no introduction. Dr. Asha Jain, ma'am. She is a director of SMSA Hospital, Raipur, medical director CPRS NGO, elected member CG Medical Council, zonal chair of FOGSI Food Drug Administration, chairman Mission Pink Health IMA Raipur, executive member of
I think that's done.
Ma'am has a great interest in all the obstetric fields, saving the uterus, fetal medicine, obstetric and gynec, critical care, preventive oncology, and colposcopy. I hand over the platform to you, ma'am, for the introduction of our speaker. Ma'am, you're muted, ma'am.
Thank you, Purvi. Thank you, all the eminent faculties to this dais. I welcome all the members and faculty from Bhimavaram, Moradabad, Muzaffarnagar, Mysore, Nadiad, Nagaon, Jaunpur, Jalgaon, and Mehsana Obstetric Gynae Societies. And I thank Society of Fetal Medicine Chhattisgarh for joining in with me in this program. I would like to welcome our Chief guest, Dr. Sunita Tendulwalkar ma'am, and guests of honor, Dr. Sujata Dalvi and Dr. Kiran Pandey ma'am. I also welcome our speaker, Dr. Aparna Sharma ma'am, who has kindly consented to speak on this topic, which is confusing to many. Our chairpersons, Dr. Archana Singh from Moradabad, Dr. Sunanda from Mysore, Dr. Kavita from Muzaffarnagar, Dr. Shubha Singh from Jaunpur, and Dr. Vilas Bhole from Jalgaon. I also welcome Dr. Ruhi from Muzaffarnagar, Dr. Hemalata from Mysore, Dr. Pinky Kataria from Nadiad, Dr. Bhaskar Sharma from Nagaon, Dr. Shaili Nigam from Jaunpur, Dr. Sheetal Bhosle from Jalgaon, Dr. Priyanshu Patel from Mehsana, Dr. Sameer Kathale from Chhattisgarh, Society of Fetal Medicine, Dr. Purvi, Executive Member, SFM Raipur, and Dr. Ritika Agrawal, Moradabad Obstetric Gynec Society. I'm very grateful that you have all agreed to join in this platform and help spread more knowledge about a very difficult subject. So with this brief, I also welcome all the delegates to make this whole program worthwhile. Now, I would like to introduce Dr. Sunita Tendulwalkar ma'am. She needs absolutely no introduction, but it is a privilege to introduce ma'am. She is President-elect FOGSI. She will take over in January 2025. She is HOD, Department of Gynae, Chief IVF and Endoscopy at Ruby Hall Clinic, Pune, advisor and consultant at Dr. D.Y. Patil IVF and Endoscopy Center, Pune, founder and medical director, Solo Clinic IVF, a center for excellency of excellence in infertility in Pune, founder and medical director of Solo Stem Cells, a stem cell research and application center, Pune. Her extraordinary achievements are that she is India's first stem cell baby and world's first at the age of 45, 16th April 2018, founded the world's first Society of Ovarian Rejuvenation in 2023. So she has so many accolades to her credit, but I stop here and I welcome you, Sunita ma'am. We would love to hear a few words of blessings from you.
Good evening, everyone. Good
Welcome,
evening,
ma'am.
everyone.
Good evening,
Thank you
madam.
so much, Asha Ji. I know in the consulting room, we are just, running from this consulting cabin to other. But what is important, I see, is the amount of societies you got connected with you. I think someone just took the name of all. So I'm not saying anything, but it's fantastic, yeah. To connect with so many societies, it's a tough job. I have gone through this phase of life of election, but I never could connect to so many societies in one go. So, Asha, probably you are too good in your communication skill. I see Dr. Sujata Dalvi and Dr. Kiran Pandey as a guest of honor. Hi, Kiran. It's lovely
Hello.
to see you all. And when we talk about the FGR, I think the best person who can speak is the fetal medicine consultant. And when you have a Aparna, I'm very sure this will be a rocking webinar of yours because lot many people would love to see and listen what are the recent updates in FGR. This CME, the way webinars and everything is happening in a OB/GYN, no other field can even imagine. In a day, there are five, six webinars happening, and all webinars, there is so much to learn and absorb. So if you miss out on one, you can catch up with the other, or you can go just back to the recording and you can hear the same speaker. So it's lovely to see everyone. Purvi, you are doing a great job with Asha. I can see that. And thank you for giving an opportunity that one fine afternoon I can meet you all, the lovely ladies here. I wish you all the best, Asha, in all your endeavor. And I'm sure you will be working with me, whether you are on chair or not on chair. You will definitely be there.
Thank you, ma'am. Thank you so much. I'm
Thank
really honored for those words. And now, after those words of blessings from Sunita ma'am, I would like to introduce Dr. Sujata Dalvi ma'am, who is our guest of honor. And I'm really indebted to both Sunita ma'am Sujata ma'am and Kiran ma'am for accepting at the first ring. So I thank you all from the bottom of my heart for accepting this invite. Dr. Sujata Dalvi ma'am is a consultant OBG at Mumbai, Gleneagles, Saifi, Bhatia, and St. Elizabeth Hospital.
That's fine, Asha. I think should be okay.
And she's associate editor of Jogi, a very knowledgeable person. I would love to have you for a lecture sometime, and thank you so much for joining in even when you are vacationing in Goa. Thank you. Welcome, ma'am.
Yeah, okay. So thank you, Asha, for a very kind introduction. At an outset, I would like to congratulate you and your team for having this Searchlight webinar. That is almost the 24th of Searchlight webinar. And the topic is very apt to the modern day obstetrics, that is late FGR. And before that, I would like to have best wishes for your future endeavor in FOGSI, that you're standing for FOGSI Food and Drug and Medical and Surgical Equipment Committee. I would also like to have the words of wisdom which have been given by our FOGSI President-elect, Dr. Sunita, and she has already invited you, whether you get elected or not. So you are already there in her team as such. And I must like to say that whosoever is logged in today, this is a topic which is of importance so far as modern obstetrics is concerned. And I'm sure those who would be giving knowledge and those who are logged in, they will learn a lot and they'll be able to implicate in their private practice for the betterment of the patient. And I must admire you that you have, collaborated with, so many societies in India, right from top to the bottom. I don't think so anybody else would be possible to do that. And wishing you all the best for today's webinar and all the best for your future endeavor in FOGSI. Thank you so much, Asha.
Thank you. Thank you so much, Sujata ma'am. Actually, I have that FOGSI list and I take societies alphabetically. And if somebody misses out, then they are included later. But that is how it goes. And that is why it's such a mix.
Yeah, but then that gives you a good variety of the societies. It's only not from one region, they're all over, that way. So that's a good mixed and amalgamation of the societies.
Thank you, ma'am. Thank you so much for appreciating that. Now, I would like to introduce Kiran Pandey, ma'am. She is the chairperson of Medical Education Committee, FOGSI, professor and FMR HOD, Department of Gynae, GSVM Medical College, Kanpur. She is ICOG Governing Council member 2021-23, peer reviewer of Indian Journal of Obstetric and Gynae since 2021. She was the president of Kanpur Menopause Society, president UP State Chapter Agai, and past president COGS and IMA.
Thank you, Dr.
Welcome, ma'am. Thank you so much for accepting my invite.
Thank you. I hope I'm audible.
Yes, you're audible now.
Yeah, thank you so much for this invite, and I'm really honored to share the dais with Dr. Sunita Tendulkar, our elect president, a very, very dynamic lady. I know, although she said it, she can't do it, but I know she has already done the job. Such a great election it was, and wonderfully she covered all over. And a well-known personality. And I'm Dr. Sujata Dalvi, another so committed persons we have in our Ops Gynae, that those who are on the leave also join just to bless everyone. So that's really wonderful to share with this. Dr. Asha, your passion and commitment is very visible and palpable everywhere. You have been doing Searchlight programs for a very long time, and in fact, I would say I am little late in joining because you tried it, but it was my misfortune that I could not join earlier. Otherwise, we have been meeting together into various conferences. So first of all, my good wishes and my heartfelt desire that you come as a chair, and my all good wishes and are there. You have been doing very hard work. Well, already everybody has said, but I really feel that it's you told me this just now
that how you select the society. Even I was wondering, some of are of UP, some of are from Maharashtra, seems to be Maharashtra, Chhattisgarh. How did you take this? But just now you told that they are from the ABCD. That's a very good way of taking six. I think almost 10 societies are there, and if that way the message and the speaker, what they say, spreads throughout the India from one corner to another. And topic you have selected is a very important for the obs and gynae. We know the high risk pregnancy which we are dealing every day, and to save, I mean, these patients, how much they are concerned for their babies. As doctor and patient both are worried. So the late FGR and early FGR and other, these things are very, very important in the day-to-day management. And who can be better than Aparna? Aparna is really one to whom we all look whenever it comes to feto-maternal medicine talk. So really everybody will be benefited, I'm very sure. I really welcome and give to all the speakers, chairpersons, and give my best wishes. And you are yourself moderating the panel, and with so many panel experts. So this program is going to be one of the very informative and very successful one. And I wish you all good luck and have a good time. And definitely lot and lot more in newer updates. We will be on new informations, new guidelines. We can get it, and by that the management through our collaborative efforts. And that's the beauty of our branch, probably, that every day we are connecting with each other, as Dr. Sunita said, and learning new things and putting them into practice and benefiting our patients. So once again, thank you very much, Dr. Asha, and good luck to you. And I love to be here the whole of the. I'll try to remain joined unless and until some important work comes. I'll keep remain here, though I'll put my video off. But I like to listen and learn from Aparna the newer updates which are coming. So thank you very much, and wish you
Thank you
good
so much. Thank you, Kiran ma'am. Thank you for all those wishes. And you will be in the program again. So
yeah, thank you very much.
So
Sure.
now with this, we end the session, the inaugural session, and I would request Purvi to give a short introduction of our chairpersons, and they would introduce the speaker.
Let's start with session 1 without any further delay. I would like to call upon all our chairpersons. Firstly, introducing Dr. Archana Singh ma'am. Ma'am has done MBBS DGU diploma in gynec endoscopy from Germany, diploma in USG from Texila American University. She has experience as a senior resident in Gangaram and Swami Dayanand Hospital in Delhi. She is practicing as a senior consultant in Naveen Hospital. She's had an expertise in laparoscopy, hysteroscopy, and colposcopy. She is active member of Moradabad Obs and Gynae Society and has worked as a treasurer, secretary, and presently is a vice president. Welcome, ma'am. Next, I would like to invite Dr. Sunanda N. Ma'am is an associate professor and unit chief of OBG department of Mysore Medical College and Research Institute. Ma'am has studied from MMC Mysore and BMC Bangalore. She has more than 15 years of undergraduate and postgraduate teaching experience. She has presented many papers and lectures in state and national conferences. She was treasurer MOGS, secretary MOGS, joint secretary Kasoga, vice president MOGS now, and has several scientific publications in national and international journals. Very much welcome, ma'am. Next, I would like to introduce Dr. Kavita Nagar, ma'am. Ma'am is the president of Muzaffarnagar Obstetrics and Gynecological Society, medical practitioner at Jeevan Rekha Nursing Home, charitable services with Jain Community, senior medical officer of Coal India Private Limited, legal cell of SMI Medico Legal Private Limited from the past 5 years. Ma'am has many awards and honors in her name. COVID Warrior Certificate from Lions Club, attended several workshops and conferences, social service, women upliftment, child welfare and education program. Her motto is health should be accessible in rural areas for Viksit Bharat. A very warm welcome, ma'am. Next, I would like to introduce Dr. Shubha Singh, ma'am. Ma'am is from, she has addressed many CMEs at various topics related to her field. She has attended many UPCONs, AICOGs, ISAR seminars and conferences, known for successful treatment of infertile couple using basic methods, also known for care of BOH cases. Her Center for Intensive Care for Complicated Antenatal Cases represented BJP in 200 MLA election. Owner of Harshit Medical Center Limited in Jaunpur, owner of Advanced Charak Diagnostic Center in Jaunpur, director of 2 Nursing School, director of Sunbeam School, CBSE 10+2. Ma'am has one of the founder members of GOGS, Jaunpur Obstetric and Gynecological Society. This was established in 2002. Ma'am is member of FOGS, member of UPCON, researched on topic of neonatal hypoglycemia following maternal glucose infusion prior to delivery. A very warm welcome, ma'am, to you too. Last, I would like to introduce Dr. Vikas Bhole, sir. Sir is President Jalgaon Obs Gynae Society and Vice President IMA MS. He is Director Matra Seva Hospital Private Limited Jalgaon, ex-Joint Secretary IMA, ex-Chairman IMA, ex-Secretary IMA, ex-Committee Member PCPNDT, ex-Committee Member PCPNDT Jalgaon, ex-Member Delegation of Kolhapur for PCPNDT, ex-Clinical Secretary GOGS, ex-Member Doctor for Daughters IMA MS, ex-member Save the Girl Child, ex-co-chairperson National Health Program, ex-member Standing Committee IMA National, ex-president BJP Dr. Cell Jalgaon 2014 to 17, advisory member Family Court Jalgaon. He has won many IMA awards. Very warm welcome, sir. I would ask Dr. Archana Singh ma'am to kindly introduce ma'am for the lecture session 1.
Any of the chairpersons would please introduce ma'am. Any chairperson present?
Good evening, madam. Can I?
Yes, ma'am.
Am I audible?
Yes, ma'am.
This is Dr. Sunanda from Mysore.
Welcome, ma'am. Welcome.
Very good evening to all of you who are present here. At the outset, I would like to thank Dr. Asha Jain, madam, the program director of this Searchlight 24, for the opportunity given to me to be a part of this live webinar. On this platform, in front of so many seniors, I like to take this opportunity to invite all of you for this FOGSI South Zonal National Conference with UA, being organized from our society on the August 9th, 10th, and 11th of this year. I request all of you for the active participation for this forthcoming conference. Without wasting much time, we move on to the scientific program of today, that is on the late FGR, which constitutes nearly about 70% of all the FGRs, and which is usually diagnosed beyond 32 weeks of gestation. Exact causes, I'm sorry, though there are no exact causes, a large degree of causes which are there as for the FGR are unpredictable. And the challenge to the clinician lies in the detection, the diagnosis, and the management. So there is no international consensus on how to define the severity of this late onset FGR, and also no optimal monitoring policies, and also regarding the timing of delivery. So in order to clear all these doubts, what we have regarding the management, the diagnosis of IUGR, we have with us Dr. Aparna Sharma, who has done her master's in the maternal fetal medicine, and she's a professor OBG department at the AIMS New Delhi. She has a fetal medicine specialist with expertise in the fetal interventions. She's been a treasurer of Society of Fetal Medicine in the year 24 to 26, Common Era Orator in the year 2007. FOGSI Junior Korean Award in the year 2018, FOGSI Sun IAGE International Traveling Fellowship in the year 2019, FOGSI Imaging Committee Award in the year 2019, FOGSI Rajat Rai Award in the year in fetal medicine. She has several publications to her credit in the peer-reviewed journals. Over to Dr. Aparna Sharma, Madam, to deliberate her lecture. Thank you, Madam.
Thank you, Chairpersons, and thank you, Asha Jain, ma'am, for having me here. So today we'll talk about. Can you see my PPT?
Can't see the PPT. It's a blank screen.
Okay.
Yes, Madam.
Okay. Okay. Is it better?
Yeah, now we can see the screen.
Right. So today we're going to talk about late onset fetal growth restriction. And I believe, like in the previous session, we had a talk on early onset fetal growth restriction. Like we have been discussing, and Dr. Sunanda also mentioned that late onset fetal growth restriction presents a lot of dilemma. Why the dilemma is that, it is difficult to diagnose. And increasingly, it has been realized that it's a bigger problem sometimes because we miss it. And it may be a cause of perinatal morbidity, mortality, stillbirths. So increasingly, we need to try and diagnose. So there are various steps to understand fetal growth restriction. It includes late, it includes early. But in general, when we try to understand fetal growth restriction, we need to follow a protocol. Now, the protocol starts by identification of a small baby. We need to say whether it's a small baby or it's a growth restricted baby, whether it's an early onset or a late onset. Why is the late onset important? Should we be screening for a late onset fetal growth restriction? If we know that it's a late onset fetal growth restriction, how do we do the surveillance and when do we deliver? So these are some of the points that we would be discussing going forward. Now, the most important thing to identify a small fetus, of course, remains the good dating. And we know that the best dating happens when we have a dating which is a CRL dating from less than 14 weeks. And if we do not have that, our next best would be a BPD between 14 to 24. And beyond that, of course, we need to take a composite dating of whatever parameters which are available. But what we really want is that to have a first trimester dating at less than 14 weeks, and we should take that. And if it is corresponding with the last... Okay, so if we have a dating which is corresponding with your last menstrual period and from the first trimester, and the discrepancy is of less than 5 days, then we take the last menstrual period. But if it is more than that, then we take the dating from the ultrasound. So first things first, we have confirmed that, okay, the dating is okay. And this baby, now we start following that baby up. Now, the second, when we have to identify, then of course, accurate measurement becomes important. And we will talk more about it as we start going and screening. How can we screen? But accurate measurement in the third trimester ultrasound, the detection rate becomes 40 to 80%. So it is important that not just the dating, but how are we measuring also becomes important. And I'll touch upon this point later on once again. So first, let us understand that dating is our first important issue that we have to be sure in the first trimester. So what exactly is fetal growth restriction? Is a fetus that does not reach its biological growth potential. And a small for gestational age is an infant who's born with an estimated fetal weight or an abdominal circumference which is less than the 10th centile. Now, why is the diagnosis of FGR important? Because a small baby may be lesser in weight, but will do well postnatally. But if it's a growth restricted baby, then the future consequences are also worse as compared to a small baby, which is growing according to its growth potential. So this is a concept which is important to understand. I have put this study here, which is the Porto study, which was the prospective observational trial to optimize pediatric health in IUGR. Now, this actually looked at the abnormal umbilical artery Doppler and estimated fetal weight less than third centile were strongly and most consistently associated with adverse perinatal outcome. And this particularly changed the definitions of IUGR that we currently use. Now, starting from here, we started realizing that fetal growth restriction, the Dopplers and the fetal growth and the fetal abdominal circumference have become suddenly very, very important beyond just the estimation of fetal weight. So when we start talking beyond the estimation of fetal weight, what we have to think about. So what is actually important is that when we have a small baby, but also which is associated, not just a small baby, it is combined with a Doppler which is abnormal, which could be the abnormal CPR, we will talk about it more, or an extremely small baby, then you have the fetal growth restriction or the IUGR or the fetal growth restriction. So a small baby combined with an abnormal Doppler, you have a combination which is the fetal growth restriction, which has a poor perinatal outcome. It could have the signs of intrauterine adaptation, and it will have a poorer prognosis. So the whole purpose of trying to identify a small baby versus growth restricted is try to identify if this baby also has a poor growth Doppler and how this baby is going to do in the postnatal period. Now let us take an example of this lady who is 32 weeks and 4 days POG, following up with us, antenatal clinic. She was following. Previously, the history and examination, everything was all right. However, when the uterine examination was done at 32 weeks, her uterus was only corresponding to 28 weeks. Now, her hemoglobin was 9 gram %. And when the ultrasound was done, her AC came to be third centile, but her estimated fetal weight was at 17th centile. Now look at the umbilical artery PI, which was 0.94, MCA PI was 2.09, CPR was more than 1, AFI was all right, biophysical profile was 8/8, NST is reactive. Now these are some commonplace scenarios which you come across, that she's at 32 weeks. Now you started suspecting fetal growth restriction. Her abdominal circumference is less, but her estimated fetal weight is more than the 10th centile. Now, keeping this case in mind, let us now unravel what can we understand from this particular case. So you see, this was her growth potential. She was following up, then she followed up with me. We did a 2-weekly growth scan, and this baby maintained the trajectory. So it's important that if this baby is maintaining the trajectory, the Dopplers have been all right. So this baby was kept on a 2-weekly growth monitoring, weekly Doppler, biophysical profile, NST, and delivered vaginally at 38 weeks with a 2600 grammer baby, alive and healthy. So this was a late fetal growth restriction, diagnosed and managed well. Now, keeping this in context, we will try and understand a few more definitions and few more management principles. So we know that when we try and define the early growth restriction, we have 3 solitary parameters, which is the abdominal circumference less than the third centile, the estimated fetal weight less than the third centile, or the absent end diastolic flow, or 4 contributory parameters, where if you have the estimated fetal weight less than the 10th centile, you should have the contributory parameters of an umbilical artery PI more than the 95th or the uterine artery PI more than the 95th. Now, this was for the early onset. But for the late onset, if you have a baby who is very small, so less than third centile means the baby is very small. So you will say that, okay, this baby has crossed 32 weeks. This baby is very small. So first time diagnosis at a period of gestation, which is beyond 32 weeks, then you will say, okay, very small baby, this is late FGR. Or you have a baby who's less than the 10th centile, but with a Doppler which is abnormal, then again, you will diagnose this as late FGR. There is another parameter which is important for late FGR, which is crossing centiles more than 2 quartiles. What does this mean? So what does this mean is that there has been a baby who in its 20-week scan, so when you did an anomaly scan in the second trimester, was at its 75th centile. But now this baby is at 25th centile. So it has fell down by 50 centiles. Although 25th centile right now is more than the 10th centile. So strictly speaking, it is not less than the 10th centile, but it has fallen by more than 2 quartiles. So that is again a definition of late FGR. So classically, the definition has been taken as 32 weeks. Now, why 32 weeks? So there is evidence to say, we will come to it, but the essential difference between early and late is the problem of late FGR is diagnosis. Most of the time, we would miss a diagnosis of late FGR. Why? Because by 32 to 34 weeks, most of the babies have grown well. So clinically, the baby, when you're doing a per-abdominal examination, you're doing a symphysiofundal height, you might tend to miss it. Again, here the placental disease is low. So essentially the umbilical artery Doppler may be normal. We'll come to it again. But the umbilical artery may be normal. So there is a hypoxia which may or may not be there. But there is central adaptation. That means the brain Doppler, MCA Doppler, that is what will pick it up. So here, interesting aspect is that the tolerance to hypoxia is less in late IUGR. So I had heard once one comparison that this is early IUGR is kind of a child who has always performed not very well in school, right? From the very beginning, this is a child who's poorly performed. So we are all expecting that this baby is going to flunk, right? We do not have very high hopes from this early IUGR. So we know what is coming. But this late IUGR baby has been a well-grown fetus, has been doing well in school. Now suddenly, this baby develops late IUGR and has stillbirth. So everybody is in a state of shock because this baby is not ready for hypoxia, has a very low tolerance. So this actually is a very, very rather high risk condition in that sense that neither the parents nor the doctors are expecting late IUGR babies to land up in problems. So this essentially is a bigger problem because the numbers are more, the proportion of IUGRs who actually have late IUGR is more than the proportion who have early IUGR. Again, they have low tolerance to hypoxia. So the complications are more. Low mortality, but poor long-term outcome. Now, some of the important questions are, why are you taking 32 weeks? Because it has been seen that if you take a cutoff for 32 weeks, then there is maximized clinical difference between early and late in terms of perinatal mortality, adverse outcomes, and association with preeclampsia. So if you make a diagnosis of IUGR before 32 weeks, you will call it early onset. But if you diagnose IUGR later than 32 weeks, you would call it late onset fetal growth restriction. Now, it doesn't mean that you probably missed everything and then you say that it is late onset. It could have had an early onset preeclampsia before, but if it's an actual early onset, then probably it should have ended up in absent and diastolic flow by that time. So essentially, it's a bit of a clinical decision, but when you start managing, you would know that, okay, an early onset would be severe early onset IUGR before 32 weeks. So we do take the cutoff of 32 weeks. Now, why is, like I've been mentioning, why is late FGR so important? The short-term consequences, of course, these babies are compromised. There is not like an obvious umbilical artery Doppler, which is abnormal, but there is a cerebrovascular redistribution. There is increased cesarean for fetal distress, neonatal acidosis, admission to neonatal unit, and cerebral palsy. So it has been seen that if you look at the risk of stillbirths, the detected IUGRs is actually 10 per 1,000, but the non-detected IUGRs is 20 per 1,000. So this is one of the biggest reasons why stillbirths are still happening. So most of our interventions are now targeted towards detecting this late onset. So that is the importance of detecting and managing late onset fetal growth restriction. In terms of long-term outcomes, it has been seen that these babies might have poor school performance, higher incidence of metabolic syndrome, adult onset diabetes. Interesting to see that, there is significantly increased incidence of diabetes in terms of the this thing, and school performances also has been seen to be poor. So it is significant, it is important. And in terms of fetal losses, failure to detect FGR accounted for 10% of the avoidable causes of perinatal deaths. So now we come to this conclusion that yes, late FGR is important. It is important to detect it. So the question remains that how soon should we start expecting it? How should we start screening it? Should we start in the first trimester? Okay, I am very worried about late FGR. This might end up in stillbirth. Should we start detecting it in the first trimester? What do the studies tell us? Now, early screening has been seen that you can detect early onset fetal growth restriction in a good proportion of cases. Although even in our practice at AIMS, we don't do screening for fetal growth restriction on a very routine basis, but we do screen everybody for preeclampsia. And when we screen everybody for preeclampsia, we know that, okay, if she's screen positive, she's predisposed for early onset fetal growth restriction as well. But early screening for late onset fetal growth restriction is limited. So I can't like jump onto the bandwagon and say, yes, late onset fetal growth restriction is so important that I must start screening for late onset right on early in the pregnancy. No, that is not the situation right now. So the detection rate in the first trimester is quite low. So I would say that no, I will not screen for late onset preeclampsia in the first trimester. What is the role of fundal height measurement? We are all medical college teachers. We love our files, our fundal height measurement charts. So, but yes, I mean, we will have the symphysis fundal height. In fact, the intergrowth charts have been incorporated by the Delhi government in their antenatal cards. And this has been shown to improve. The evidence shows that if you incorporate not just fundal height, but symphysis fundal height measurement in your routine practice, it might improve the detection rate of late onset fetal growth restriction. So the detection rate is close to 50% with a false positive rate of 10%. So yes, don't just do a fundal height clinically by that palpation method. Use a tape, do a symphysis fundal height, and plot it on the intergrowth chart, which is available for symphysis fundal height. So it shows that 60% false positive, although limited value, it continues to be the only physical examination and screening test available. So yes, I would say we must all stick to the practice till now, but we cannot just rely on only symphysis fundal height. Being a fetal medicine person, I would say that we cannot only rely on symphysis fundal height. We must think beyond that also now. So we come to the next part, which is fetal biometry. Is there a role of routine ultrasound in late pregnancy? Now, I have spelled out this question very, very slowly, and I would say a lot of people would say otherwise, this way, that way. And a Cochrane review in 2015, they said that the routine trials have failed to demonstrate benefit. But the technology and expertise in 70s and 80s does not translate legitimately into clinical practice. All of these studies were quite old. Again, more recent data has shown that SGA showed an AOC of 88% and a detection rate of 70% for SGA. So in a more recent study where the gestational age at scan was 32. So the main question is that should we be doing a systematic ultrasound or a focused on selected population of high risk for detection of fetal growth restriction? Again, which parameter should we be looking at, estimated fetal weight or AC? What is the optimal gestational age at which we should do the ultrasound? So it has been seen that we know that this very famous POP study, which was published in Lancet, and which told us that if you screen these women with a routine ultrasound, universal screening triples the detection rate of SGA as compared to screening based on clinical risk factors. And I can say that if possible, we are offering. In our clinical practice, we offer at least one ultrasound in the third trimester, preferably at 36 weeks, for a routine detection of late onset fetal growth restriction. And I think in settings which can afford it, that is a reasonable practice. Again, the second question would be estimated fetal weight versus abdominal circumference. So we know that ACOG supports the use of only estimated fetal weight, while ISWOG and RCOG supports the use of AC less than 10 centile as an add-on criteria. It has been seen that both are comparable. So any one criteria which is less than the third centile, so even if it's like one criteria which is extremely small, less than the third centile, it becomes important and it must be taken into account. Ideally, any one center, if you're following, you should follow one criteria, stick to it, and then follow that particular criteria. But if something is really small, then you can't simply ignore it. So that is something. And more importantly, as we all believe, it is not one single value which is important, but we need to put a trajectory on how the AC is growing, how the estimated fetal weight is growing, which is more important than a single value. Again, a very, very important question. If somebody wants to do a single growth scan in the third trimester, what is the optimal gestational age? And I think everybody would agree. Now, with this randomized trial, which is the root trial, 36 versus 32. So 36 was superior. And in clinical practice, we now prefer doing it 36 single scan at 36 weeks as compared to 32 weeks to detect late onset fetal growth restriction. And I think that's something which is extremely, extremely important. So is reduced growth velocity important? Like one of the criteria is crossing of centiles. Now, is that important really? So various societies have mentioned like crossing of centiles, change of AC, but it has not been really seen to be extremely important and not very, very important in making a diagnosis or prognosticating. So after having discussed all of these issues for diagnosis, screening, and trying to establish the entity of late fetal growth restriction, let us just take a moment to summarize when do we call it late onset fetal growth restriction. So number one point would be when the gestational age is more than 32 weeks, in the absence of congenital malformations, estimated fetal weight or AC is less than the third centile, or if the AC and AFW is less than the 10th centile, then it is crossing more than the 2 quartiles, or the CPR is less than the 5th centile, or the umbilical artery PI is more than the 95th centile. So between 3rd to 10th centile, you have to have at least one Doppler abnormality to say that this baby is fetal growth restricted, right? Now we come to the second aspect, which is the Doppler parameter. Important aspect to mention here would be to say that umbilical artery Doppler does not reliably reflect placental insufficiency. It may be normal in late onset fetal growth restriction. So even if you have a baby which is small, less than the 3rd centile, the umbilical artery Doppler may be normal, because as we discussed, this late onset growth restriction is not actually a placental disease. This is a placental not insufficiency, but it actually placental maladjustment. So this is something that it's placental under perfusion. So this is not reflected in umbilical. So please be very careful. We cannot be sitting very easy that, okay, umbilical artery Doppler is normal, we are okay. So that is something that we need to be careful. Again, uterine artery Doppler may not be clinically relevant, right? Of course, it may reflect placental insufficiency. So if the umbilical uterine artery PI is raised, then we can say, okay, there is a uteroplacental cause, but it will not help you establish the management point. So abnormal uterine Doppler has a twofold increased risk of developing abnormal brain Doppler before induction of labor. So again, it has a use in prognosticating. So umbilical artery Doppler, uterine artery Doppler do not have clinical relevance, too much of clinical relevance. Uterine artery Doppler does not have a clinical relevance, too much clinical relevance in management. Umbilical artery Doppler, be careful that it may be normal, right? So that's important point to remember. What is important is MCA. Now, why is MCA important? Because it is useful to predict adverse outcome 6 times as many instances of emergent cesarean delivery. Now, it is associated with what is CPR. So CPR is again an important aspect to be discussed here. Why? Because as I discussed, umbilical artery may be normal. What is happening is that the brain is getting relatively more supply as compared to the other parts of the body. So the MCA PI is changing, umbilical artery PI has not changed. So what really happens is the CPR becomes abnormal as compared to the umbilical artery PI. So it is associated, it is more useful in late onset FGR, and impaired CPR is seen in up to 25% of late onset fetal growth restriction. So if the CPR is abnormal, it is associated with poorer perinatal outcome, both at birth and 2 years of age. And it is more sensitive to hypoxia as compared to its individual components. And it has been seen clinically evidence-based that it predicts a risk of cesarean delivery and, of course, the increased risk of fetal distress. And also there is an increased risk of stillbirth and adverse perinatal outcome. So if we have to understand Doppler, MCA Doppler is more important. CPR is even more important, the ratio in terms, because MCA may be normal, umbilical may be Doppler normal, but the ratio may be abnormal when we talk about late onset fetal growth restriction. Now we have made a diagnosis of late onset fetal growth restriction, like in the case that we discussed, the late onset fetal growth restriction, a diagnosis was made because the estimated fetal weight was less than the 3rd centile. How do you plan to monitor this lady? So, like in the early onset, the progression is not linear. We don't know. So it's not associated with hemodynamic changes which are linear. So we need to have various modalities for surveillance include growth, Leica, MCA, and CPR. So serial growth assessment. So please remember, if you diagnose a baby at 32 weeks, we do not go about doing growth every week. So it should not be performed more frequently than 2 weeks, because there are inherent associated problems with the ultrasonographic measurements. The role of Leica, and I think I would like to take a moment here to say that Leica has been always given more importance in clinical management than probably the evidence has shown. So no association with acidosis or perinatal death. Inclusion of oligohydramnios in the management protocol is not recommended. In fact, nowhere in the management protocols for FGR there is any mention of Leica. But yes, clinical judgment is paramount. I would not say that, of course, there is oligohydramnios and hydramnios, but you still go on managing this patient based purely on protocol. But yes, largely speaking, Leica has limited role, and it is associated with intrapartum FHR abnormalities need for a cesarean section. So more strict vigilance for fetal heart monitoring. So in the presence of an umbilical artery Doppler more than 95th, monitoring is at least once or twice a week. So we will discuss this little bit more in detail. So now suppose this particular lady or your patient is between 3rd to 9th centile, right? And your fluid and Doppler and everything is normal. This is a late onset fetal growth restriction. Your risk of stillbirth is low. So you will recommend growth every 2 weekly. You will recommend Doppler every 1 to 2 weeks. And at more than 37 weeks, you will consider biophysical profile and NST 1 to 2 times per week. And timing and mode of delivery is between 37 to 39 weeks. And the mode of delivery can be vaginal. So this is a surveillance strategy which we must remember: 2 weekly growth and a weekly Doppler. So this is something that we follow for every patient, like we mentioned previously also. If normal fluid and the AC is less than 3rd centile, more or less the monitoring remains the same. The timing of delivery can vary between 36 to 38 weeks. Again, 2 weekly growth and weekly Doppler. So mostly this is our protocol for follow-up that we follow at most times. Now, in terms of, if your early Doppler changes, umbilical artery PI is more than the 95th centile, or CPR less than the 5th centile, uterine artery PI more than the 95th centile, oligohydramnios, but otherwise other problems like preeclampsia, then we need to understand what are the other maternal factors. Again, growth every 2 weekly, Doppler 1 to 2 times per week, consider steroids for fetal lung maturation, consider inpatient monitoring, and delivery between 34 to 37 weeks. Now, strictly speaking, if we are planning to deliver a patient even 1 day before 37 weeks, we need to understand why we are delivering this patient even 1 day before 37 weeks. So we will not deliver a patient before 37 weeks. And I will come to that once again, that we won't deliver a patient before 37 weeks based only on CPR changes. If there is a change in umbilical artery, only then we will have to. So if there's an absent and diastolic flow or there is something else, then we will consider change or a delivery before 37 weeks based only on CPR. Because this is, I am actually insisting, because although I have talked about the importance of CPR, let it not go as a message that CPR abnormality is an indication for delivery. I am waiting on this slide and re-emphasizing this here, that CPR abnormality indicates need for surveillance, indicates need that, okay, this baby needs surveillance and it would probably have fetal distress in labor. But at any point in time before 37 weeks, the CPR abnormality does not require termination of pregnancy. So it's very important that the umbilical artery Doppler needs to be monitored and the pregnancy needs to be continued. Now, in just another case, 34 weeks and 4 days, IHCP, diabetes, moderate anemia, stage 1 FGR. So 34 weeks, the uterus was 30 weeks of pregnancy. So this was fetal growth restriction. The abdominal circumference was less than 3rd centile. Estimated fetal weight was less than 3rd centile. The umbilical artery PI was more than 95th centile. And the CPR was less than 1. And the umbilical PI, MCA PI was less than the 5th centile. So we see that, even all the Doppler abnormalities were also there. This lady was also followed with a 2-weekly growth. Weekly, bi-weekly Dopplers were done, biophysical profile NST. Patient was delivered vaginally 37 weeks by elective induction of labor. This baby weight is less 2200 grams. So here we understand that even if you have an abnormal Doppler, the point is to give surveillance. Unless you have a reason to deliver before 37 weeks, you're not justified in delivering. So the timing of delivery is very clearly given in this particular guideline, and we do follow these guidelines, right? Between 32 to 34 weeks, 33 weeks and 6 days, what is the indication for delivery? If you have a absent or a reversed flow. So before 34 weeks, if you have an absent or a reversed flow or a short-term variability which is reduced, then you deliver. A raised umbilical artery, CPR reversal, all of that is not an indication for delivery. Again, more than 34 weeks, but less than 37 weeks, 36 weeks, you will not deliver unless there is an absent and diastolic flow. So umbilical artery decides the delivery before 36 weeks. Here, between 36 to 38 weeks, again, umbilical artery PI more than the 95th centile, along with an AC less than 3rd centile. Here also, if you see, the MCA has not come till here. So even up to 38 weeks, it is based on the umbilical artery Doppler and fetal growth. So as a policy, we do induce fetal growth restrictions between 37 to 38 weeks if they have fetal growth restriction with an estimated fetal weight of less than 3rd centile or an umbilical artery PI which is raised. If you have only cerebral redistribution, that is only MCA or CPR which is abnormal, but the umbilical Doppler is normal, then you can take your pregnancy up to 38 weeks. And this is extremely important that we don't deliver our babies of late fetal growth restriction early. Now, it's extremely important because I have been talking about that there is cerebral redistribution, there could be poor outcomes. In all of this, the message is not to deliver preterm. The message is to do a good surveillance. The message is we must tell the women to have fetal movement count, have a weekly Doppler, have a 2-weekly growth, and do a good biophysical profile. So that's the point of understanding late fetal growth restriction, so that we are able to deliver these babies on term and yet avoid a stillbirth. So these are some of the things that we would like to say. In all of it, if there are ADF or REDF at any point in time, you would like to deliver them, or spontaneous, unprovoked, repeated deceleration, again, you would like to deliver. So, in pregnancies with late FGR, delivery should be based on biophysical assessment and maternal indications as discussed, or if you have spontaneous, repeated, unprovoked decelerations, altered biophysical profile, other maternal indication, or absent or reversed in diastolic flow, then you deliver. Between 36 to 38 weeks, depend on the umbilical artery PI. After 38 weeks, if there is cerebral redistribution, again, or any other feature of FGR, then you will deliver these babies. So this is the Barcelona protocol that we always discussed. If it is stage 1 FGR, which is estimated fetal weight less than 3rd centile, CPR more than 95th, MCA less than 5th, then you deliver at 37 weeks. If you have AEDF, anytime after 34, you deliver. If you have reversed in diastolic flow, deliver after 30. And if you have REDF with decreased STV, anytime after 26, you deliver. So essential to understand that stage 1, you need to take 37, stage 2, 34, stage 3, 30, and stage 4 anytime. Thank you very much. And if there are any questions, we can take them.
Thank you so much, Dr. Aparna. Requesting chairpersons. Dr. Kavita, ma'am, you're there. Dr. Kavita, ma'am. Uma Pandey, ma'am, welcome. Ma'am is past president from Varanasi. Sunanda, ma'am. Yes, ma'am. Any comments that you want to make? Dr. Uma Pandey, ma'am.
It was wonderful, Dr. Aparna. Dr. Aparna is from BHU and I am in BHU. So there's a bond there. And so no, it was very beautiful. It was wonderful deliberation you made, and the Barcelona classification and importance of oligohydramnios, everything was very, very, very well said. The only thing I want to say, and sometimes in our institution, the patients, they come like they will suddenly come at 33 weeks gestation. You are doing ultrasound examination that shows that there is oligohydramnios, there is also CPR ratio is reversed. But at that moment of time, nobody is paying attention to umbilical artery Doppler, because she's also, because you're worried about these two things and patient has come to you for the first time. So what you would do, I know, I mean, yours is a premier institution, but what would you do in a patient who has just come to you, you haven't had any history of hypertension or any other medical morbid condition you do not know. So what to do?
Yes, ma'am. So I think that's a very good question, because we do also get such referrals coming from all over the place. So first of all, I think, as you would say yourself, that, just see whether there's any high blood pressure, history of high blood pressure. What was the uterine artery Doppler in the first trimester, if it was done? Is she
nothing was done.
Right. And what is the uterine artery Doppler at the present time? Because that also suggests uteroplacental insufficiency. So I think that is something that I would also look at. Then, of course, I would look at the overall fetal growth. Is she having fetal growth restriction at the present time? Is the estimated fetal weight less than the 3rd centile? Because that will corroborate that, okay, this is late onset fetal growth restriction. And then she's supposed to have, oligohydramnios along with it. Of course, there is a history of leaking. So now, if there is a fetal growth restriction, along with that, what is the umbilical artery Doppler? Is it raised at the present time? And along with that, is there oligohydramnios? Now, if there is an umbilical artery Doppler, which is raised, along with that, if there is oligohydramnios, I would continue that pregnancy.
Okay.
Because I would like to go till, like I've been mentioning time and again, that I would like to go till 37 weeks. That is something that I would like to go. But yes, with caution, if something like, I would say, if it is oligo persistent, like, if it is increasing, even 36 weeks. But 33, 34 is not something that I would deliver. Oligo, as evidence has shown, that it does not really harm, affect the prognosis. If the umbilical artery Doppler is raised but present, it's not absent. If it is absent beyond 34 weeks, I will deliver. If it is present, the flow is present, even if it is raised, I will go on till 37 weeks. I will try to go on with, of course, cautious monitoring, weekly Dopplers, bi-weekly biophysical profile. I will go on till 36 to 37 weeks. I mean, that is something that I would like to do.
Okay, one more question. Am I allowed to ask one more question?
Go
Okay.
ahead, go ahead.
Thank you, ma'am. Thank you so much. The liquor is also responsible for lung development. And when we were little, when we were postgraduates, we were taught again and again that that liquor is there. If not, then pulmonary hypoplasia will happen and this will happen. Then this evidence which you produced, where do they stand regarding lung development? And you are saying oligo hasn't got much role
Yes.
to play. Yeah.
Yes, ma'am. I think that's a very good point. But it's also been seen that, lung development actually happens in 2 phases, right? So one is actually the early phase, which is, from 20 weeks to 24 weeks. Even this has been proven by the CDH thing that really happens. So that is the period when the liquor should have been there. At that point in time, if the primary canaliculi have been formed, now
Okay.
that lung development has happened. Right now, at this point in time, it is more important to gain gestational maturity, right? And right now, if you deliver, you will actually have to give steroids to deliver. And then probably you need surfactant after delivery. So
Yes.
why do we want to do that? So if that baby had liquor around itself at the time when the primary and the secondary canaliculi was being formed, we are more than happy. Right now, at 33, 34 weeks, liquor has not that much of a role in lung development. Rather, it is the gestation which is important for lung development.
Okay. Thank you so much. Thank you.
Ma'am, I
Thank
have
you,
a
Dr. Aparna.
question.
Yes, Dr. Shelley, go ahead.
It was very nice, very informative presentation, ma'am. Thank you for that. I would just like to reconfirm, like you told that at 36 weeks we should go for the scan. But
Yes.
though, ma'am, like in 3rd trimester, straight away we get a scan at 36 weeks only. But
Yes.
what is your routine protocol of routine
Yes.
ultrasounds?
Yes. So essentially, one scan for fetal cardiac activity confirmation, one scan at 11 to 14 weeks, one scan for the anomaly scan at 18 to 20 weeks, and just do a clinical monitoring. If this patient is all right, then a minimum one scan at 35 to 36 weeks for growth. If you find that this patient, but this is a low risk protocol. If at any point in time you find that the fetal growth is lagging at 28 to 30 weeks, then of course you will do the scan, right? But this is like everything is okay clinically, but this is like, because earlier people would not even do a scan in the 3rd trimester. Right. So we have 2 Indias, right? One where people do 12 ultrasounds and other where people not even do 1 ultrasound. So what we are trying to say is that at least do 1 ultrasound in the 3rd trimester so that, the risk of stillbirth is averted. If you detect fetal growth restriction at 36 weeks, at least you will deliver them at 37 to 38 weeks and not take them till 40 weeks.
So
That
right now, like, ma'am, what I am doing, I do a scan at 32 weeks. So
You can
that means
shift
I
it.
should shift it to
Yes.
36 weeks.
Yes. Because why? Because the study has shown that the detection rate at 32 weeks is 30% and the detection rate at 36 weeks is 60%.
60%. So that should be a Doppler. Complete or
Yes, whenever. So essentially, again, the question is, Doppler is just about putting one button, right? But the thing is, if it is indicated, you put it. If it is not indicated, you don't put it. If you don't find a fetal growth restriction, why would you do a Doppler? If you find an AC which is less than 10 centile, why will you not put a Doppler? So it's
yeah.
just that, right?
Okay, thank you, ma'am.
Kavita ma'am, would you like to say something?
Yeah, good evening. And also, hello. Am I audible, ma'am?
Yes.
Yes, ma'am.
Okay. Good evening, everybody. It was nice talking. Dr. Aparna, you gave us very nice information. I just wanted to know, although we go for a good clinical assessment for an optimal neonatal outcome, we do always try to make the pregnancy reach till maturity. And now you have explained us that we should reach till 37 weeks. Is there any role of counseling with the attendants as well as the patient, what we call a family meeting, where we suggest and explain them what exactly is going in their particular patient's point of view, and can we explain them regarding the, and this is why I'm talking is we are thinking other way around also, because we are also sometimes sued medico legally कि सब ठीक ठाक चल रहा था and all of a sudden क्या हो गया doctor, to explain those facts.
Yes.
So do we go for a good communication in this
Yes.
particular level of time, and what is the role of dietary intake and fluid replacement as we go for amino acid infusions? Does it play any role at this juncture of life?
Yeah.
Or it's just a psychological build up on the part of the patient?
Yeah. So, ma'am, I think you have two questions. For the first question, I would like to say that in our clinical practice at AIMS here, we have something we called a birth plan that we talk about routinely between 34 weeks to 35 weeks, where we talk about what should be your mode of delivery, what should be your time of delivery, what should be who should be your birth companion, labor, analgesia, postpartum contraception. In that, we do discuss that, see, you're having fetal growth restriction and you will be delivered by 37 weeks, such and such is your maternal risk factor, such and such is your fetal risk factor. So communication, and so something around 34 to 35 weeks, it's extremely essential that we communicate the birth plan to the relatives, so they are aware that this is a low risk or a high risk pregnancy and what is your approximate time. So if you have preeclampsia, diabetes, or ICP or fetal growth restriction, you are likely to deliver by 37 to 38 weeks, or if you don't have anything, you will go on. Again, TOLAC, no TOLAC, so all of those issues can be discussed around that time, so it's extremely important. Now, regarding the second part about amino acid infusions, fluids, we don't give. There is not enough evidence to do that. Even if the patient is having FGR, any other thing, there is not enough evidence to say that we should be giving it. No.
So good clinical
Archana ma'am,
assessment is the mainstay.
Aparna ma'am, I have one question from somebody in the audience. Dr. Ruchi Bhargav has asked that why not routinely do a 28-week scan when it is a watershed line between early and late and problems?
So that's a good question to ask, but who decides the watershed line? The evidence has to come up, right? So basically, like why I said is, why did we decide 32 weeks for early and late? Because that is the place which decides the most of the clinical disparity between the early and the late onset fetal growth restriction. Now, if you do a routine ultrasound at 28 weeks, your baby might have been normal, but the later on it may develop fetal growth restriction. And then you are again missing a late onset fetal growth restriction. So if you have to do one scan, you need to do at a time where you are able to pick up the maximum number of late onset fetal growth restriction.
If you can do two.
So if you see the POP study, POP study did at 28 weeks, 32 weeks, 36 weeks. The detection rate was best at 36 weeks. So if you have so many scans to do it every time. But yes, I mean, you need to prioritize, right? So if you can do it 28 weeks, 30 weeks, 32 weeks. But yes, if you have, I mean, one scan, 36 weeks, two scans, 28 weeks, of course, you're picking up, going into the third trimester. But I mean, I can't justify 28 weeks, no. There is no evidence to say that, yes.
So what would you say? What is the minimum which will yield maximum results? How many
36.
ultrasounds do you
So
want?
I would just say again, 3 basic ultrasounds: NT&B scan, anomaly scan, 36-week scan. Yes. And if 36-week scan has not yet come into any guideline, but I would say going forward, we do it, and we must try and incorporate in everything. Yeah.
If at any time you see something which is not matching, then you would go ahead
Yes,
and
of
do it.
course.
Here,
I mean,
what
this
you're
is
talking about is just
low
routine.
risk. Yes, is low risk. Please understand. If you see something, you cannot say, no, I will do it 36 weeks. No, please, this is not done. If it is also, if she's a known high risk, you would probably start scanning from 28 weeks. I agree to that. If she is known to be high risk for preeclampsia, or she's a previous APLA syndrome, or you suspect fetal growth restriction in that particular case, you RCOG guidelines on high risk pregnancy prone to FGR, you will probably start doing from early onset. So I'm not saying that even in a high risk, don't do. Yes, you do. And even we do it at high risk pregnancies. But in a low risk, low primary gravida, no other high risk factor, one scan, 36 weeks.
Okay. Thank you so much. Thank you so much.
Ma'am, I have a question.
Go ahead.
Ma'am, Aparna ma'am, just you told just now that even if the FGR EFW is less than third percentile and the Doppler flows are normal, then you have to do scanning. I mean Doppler every weekly. So is
Yes.
it necessary to do that frequently? Can we go for 2 weeks Doppler? Because the first Doppler is normal, absolutely normal.
Acha. So Sheetal, I would like to say that, we can, you can do what we want to do, but it is written. I mean, see, currently we go by what protocols have been laid down for us. The protocols say weekly, right? But it is 1 to 2 weekly. Yes, like I showed in my PPT also. If the estimated fetal weight is between 3rd to 10th centile, it is more likely to be 1 to 2 weekly. If it is less than 3rd centile, it is preferable to be weekly. Right. So this is what the ISWO guidelines say. But yes, this is evidence which has been, this is actually extrapolated from the evidence. And it is
Okay, ma'am.
preferable. Okay. So
Yeah.
nothing is written in kind of stone, but this is what we do and it is preferable to do.
Yeah, sure. Thank you.
Anybody has any more questions? Aparna ma'am, do you have the time or you need to leave?
I must leave.
Okay. So then thank you so much for being here and sparing your whole evening in spite of a very heavy OT day. So thank you so much. Thank you,
Thank you for
respected
having me today.
chairpersons. I hope we are able to catch you one more time for something else.
Sure. Thank you.
Thank you so much. Thank you, chairpersons. Dr. Archana, Dr. Sunanda, Dr. Kavita, Dr. Shubha, and Dr. Vilas. And now we would proceed to the panel. I'm requesting everyone, please put on your videos. It's very difficult to run a panel when I can't see anyone. Very difficult. Uma ma'am, can you spare the time and be there, or you want to leave? Uma Pandey ma'am? Disappear. You're muted. You're muted.
Yeah, I will have to go after some time. Maybe another 30 minutes I can be with you. After that, I will have to go for round now.
Okay, okay. Dr. Ruhi, would you please put on your video? Dr. Sameer, requesting you. Dr. Shelly, please put on your videos and I will start sharing my screen.
Yeah, I'm here on.
Thank you. You're driving?
I'm reaching in 5 minutes. I will be stable within 5 minutes.
All right. All right. So, welcome to this panel. And the panel is on late FGR. So, see, what we are going to do here in this panel is we are just going to reiterate what Aparna ma'am has already said. Because when you hear it, everything seems yes. But when you're applying it, you sort of get confused. So we will discuss things that she as a fetal medicine person did not speak about, but we need to know about. Because we are obstetricians, we are also managing the patient. For those of you who have not done nominations from your society, I request you please nominate me for Food, Drug and Medical Surgical Equipment Committee. Thank you so much if you have already nominated. Now, our panelists, Dr. Ruhi, Dr. Hemlata, Dr. Bhaskar, Dr. Shelly, Dr. Sheetal Bhosle, Dr. Priyanshu, Dr. Sameer Kathale, Dr. Purvi Agrawal, and Dr. Ritika Agrawal. Half of them are caught up in emergencies. So we will go on with those who are present here. We have Dr. Ruhi Karnwal. She is the secretary of Muzaffarnagar Society. Welcome, Dr. Ruhi.
Good evening, ma'am.
Good evening. Good to see you.
Same here, ma'am.
We have Dr. Hemalata CR. She's the secretary of Mysore Society. She just messaged that she's in an emergency and is unable to log in. Dr. Pinky Kataria, she is from Nadiad Society. Dr. Bhaskar Sharma from Nagaon Society. Dr. Shaili Nigam, we've all heard her. She is from Jaunpur Obstetric Gynec Society. Dr. Sheetal Bhosle from Jalgaon Society, the secretary. Dr. Priyanshu Mehsana, secretary. Dr. Sameer Kathale, secretary of SFM Chhattisgarh. Dr. Purvi, we've all been introduced to, the executive member of SFM Chhattisgarh. And Dr. Ritika also messaged that there is some problem with her net. She's unable to actually continue with her net. She is from Moradabad Obstetric Gynec Society. So I haven't divided any questions. Anyone can answer whatever they want to answer. So my question starts with, how do you actually define late FGR?
Late onset.
Yeah, Sheetal, please go ahead.
FGR is basically, it is defined as the failure of the fetus to meet its biological growth potential, and it is due to some pathological cause, and when it is diagnosed beyond 32 weeks, when we call it as late FGR.
Okay, so Ruhi ma'am, what is the incidence?
Late onset FGR, they count for around 5 to 10% cases of the FGR.
Okay, Purvi, do you want to add something to that?
Yes, ma'am. So late FGR accounts for almost 70% of FGR fetuses and 10% of all pregnancies. In that also they have divided high income and low income countries. High income countries, the incidence is relatively less, around 8 to 10%. Low income, it is around 20% of all pregnancies.
So that means with so many births, one mini Australia being born every day, the number of late IUGRs would be huge in our country. And is it easy to diagnose, and how would you diagnose it?
Ma'am, it was well discussed in Aparna ma'am's lecture.
Yeah, that is why this is just a bullet.
So to diagnose, first thing we should look for AC and estimated fetal weight of the fetus. If it is less than 3 percentile, then only single factor will matter, and we can straight away say that she is having IUGR fetus, growth restricted fetus. But if AC or estimated fetal weight is in the range more than 3 percentile but less than 10, then we need to get more factors to diagnose it as FGR. We need to follow the patient, and if we get associated Doppler changes, then we can call her as growth restricted fetus.
So one thing I want to ask you, that this is, you're talking only about ultrasound, but Dr. Ruhi, when would you actually order an ultrasound? You are seeing the patient regularly. When would you actually ask for an ultrasound for this patient?
And the normal ANC, as per normal ANC protocols, the first ultrasound which is being done is an NGNB
No,
scan.
that's okay. Now she's in her third trimester. And the protocol is 36 weeks, but you are ordering it maybe after 32 weeks. So what triggered that? What was the trigger to advise that ultrasound?
On clinical examination, if the symphysiofundal height is not corresponding to the period of gestation, then definitely an early third trimester ultrasound will be ordered.
Okay, that is very important, that we need to remember that clinical examination has to be properly done, not just listening to the fetal heart and letting the patient go. Okay, so is it easy to diagnose or is it difficult to diagnose?
Late onset is difficult to diagnose.
Difficult to diagnose.
Difficult to diagnose. And is it easy to monitor or is it difficult to monitor? Sheetal ma'am, Dr. Sheetal, आपसे पूछ
I
रही
feel
हूँ.
after Aparna ma'am's lecture, I feel the monitoring part is quite simplified, and it would be easier to monitor if we follow her steps. Because
Yeah,
what
so
she told, it
you
would
need
be
to
easier.
follow the guidelines.
Guidelines, right?
Right.
See, ma'am,
So-
in this we need to see that like routinely in early onset FGR, there is proper sequence of changes, and initially there is umbilical artery changes, Doppler changes, then only further changes are seen. But here in late onset FGR, it has been discussed that many a times umbilical artery Dopplers are normal. So it may be difficult to diagnose sometimes these patients.
See, in late FGR, I will come to the fetal medicine people later because these are questions that I'm directing basically at gynecologists. That is ultrasound or a Doppler a trigger for delivery in late FGR? I'm not talking of early here. In late FGR, is Doppler a trigger for delivery?
Ma'am, may I answer the question?
Yes, yes, please go ahead.
Hello. Yeah,
Yes,
ma'am,
yes,
as
Dr.
Dr.
Sameer,
Aparna
go
already
ahead.
said. Yeah, as Dr. Aparna has already said, there's Doppler changes. Are significant aspect. Good point. That she has emphasized a very good point that even if we are getting mild shift in the Doppler in umbilical artery, not to worry, and including CPR also. If there is alteration in the CPR, then also it is not to be worried until unless we get a reversal or an absent diastolic flow in the umbilical artery. Then only it is a triggering factor.
So basically, these ultrasound findings and Dopplers are not the triggers for delivery in third trimester. So what are triggers for us? When CTG may there is decreased variability, when there is loss of
When there is
fetal
repetitive
movements, biophysical
profile. When biophysical profile is less than 4/10 and there are repetitive fetal heart rate decelerations, or there might be some sinusoidal pattern on the CTG, and beat to beat
so
variability
basically
is
here
sustained.
we are very worried about the biophysical profile.
Oh, yes, ma'am.
Which has to be seen. Now, this is another question again to the gynecologist. Can a fetus with 10 to 90th percentile, a weight between the 10th and 90th percentile be growth retarded? All
Yes,
your
ma'am.
definitions, 3%, less than 10%, but it is between 10 and 90. Can it still be growth retarded?
Yes, ma'am. If we find AC less than 10 percentile, such we can see find some fetus who are
No,
normal.
I'm saying it's more than 10. It's more than 10.
Yeah. But
Yes,
ma'am,
then
in AC, weight is normal, but abdominal circumference.
That is both are above 10 centile.
Okay.
Still,
if they are not following the trajectory during the interval growth scan, if they are not following the trajectory, then there is definitely a growth retardation.
So that point we tend to forget, that if it has fallen below 2 quartiles. So if it was 90 and it has come down to 40 or 30, even then it is growth retardation. So what are the intrapartum complications? You have taken this patient. What are the problems you expect for her to deliver?
There are more chances of intrapartum hypoxia in these patients, fetal distress, and passage of meconium aspiration, and increased perinatal asphyxia, low FGR score in these patients, more chances of neonatal admissions in these patients.
So chances of fetal distress and being taken for cesarean, failure of induction, all these problems can occur. Okay, and then there are perinatal problems. So this I've already asked, the trigger for delivery. So what is the mode of delivery? Are you going to do a cesarean for everyone, or are you going to try to induce?
We can go
She
for
is a
induction.
case of FGR. She is at 37 weeks, 4 days.
Ma'am, we can induce her if she has. We will monitor her during labor, and she definitely can go for normal delivery, vaginal delivery. If there is any intrapartum distress or non-progress, then we can take her for cesarean section.
Okay.
With a continuous CTG monitoring.
Yes. So what is the contribution of late FGR to stillbirths?
Very high.
So what is the percentage? About 43% of stillbirths are associated with late FGR. So that is a really huge number. And we need to remember that if we are able to monitor late FGR properly, at least a certain percentage of those deaths can be prevented. So can it be prevented? Can late FGR be prevented?
We can predict.
We can predict and monitor, but I don't think we can prevent.
You cannot prevent it, right?
You cannot.
So can it be predicted?
It can be predicted by uterine artery Doppler done in NTNB scan and during level 2 scan.
One thing I want to ask you, that if this late FGR is associated with late onset PIH, and we have done our PIH monitoring well and kept her on aspirin, don't you think this can be prevented? Come on. Can it be treated?
May I add something?
Yes, please. Yes, Samir.
Ma'am, nowadays, yes, ma'am.
Your voice
Nowadays,
disappears.
preeclampsia screening can be done even in the first family scan. And okay, ma'am, we can do preeclampsia screening even in the first trimester itself. So
yeah, that's what
it gives us an idea about. Yeah, that gives us an idea about the upcoming events, either late onset IUCR or an early onset IUCR. So there.
So there are certain things that are preventable. Early diagnosis.
Uterine artery Doppler plays a very important role in the first trimester.
So we can prevent PIH. We can early diagnose infections. We can also diagnose Apla syndrome. And if we are able to manage that, we can manage the FGR that is caused because of them. But what the cause we don't know, that we cannot prevent. Okay, now we come to the treatment. Is there any role of progesterone? Baby is growing slow. Do you want to add progesterone?
No, ma'am.
No. Is there any role of enoxaparin or heparin?
At this stage, if you start it early, like we.
No, here now at 32 weeks.
No, I don't think, ma'am. At this stage, there is no rule.
Aspirin?
No rule.
No. Immunoglobulins?
No rule, ma'am.
No role. Any role of vasodilators?
Vasodilators, ma'am. Certain studies.
Like
shown to show some
yes,
results.
Please.
If given in a dose of 25 milligrams thrice day, sildenafil has shown to give some benefits in FGR fetuses.
Okay. So, do you want to add calcium? Kavita ma'am had asked, is there any role of the proteins and all that we gave, L-arginine and all? Is there any proven benefit of this?
No, ma'am.
No. Dr. Sheetal, what would you like to say? Dr. Ruhi? Yes, Dr. Sheetal.
apart from sildenafil, there are no proven benefits of any other medical, medical, there is no role of medical management here, apart from sildenafil.
Okay. And sildenafil trial is still ongoing. So Purvi, would you like to add something here? Because when you're working and patients come to you, they would be taking all of these drugs sometimes. Do you see any benefit?
So, as of now, ma'am, there is nothing proven. There is no guidelines which tells, yes, this drug is effective and it should be given. But if a patient comes and we are the managing doctors, benefit of doubt, we try to give them all the mixtures and we try to prevent the progress of the FGR as much as we can. But as current guidelines are there, nothing as of now has proven any benefit for late onset FGR if not predicted or prevented early. That means if we know the cause and we give a prevention for that,
Okay. So what is the etiology? What is the etiology? Dr. Sheetal? Dr. Ruhi, would you like to say this?
Ma'am, the causes can be either maternal or fetal or the placental. Maternal causes like chronic hypertension, preeclampsia, gestational diabetes, or substance abuses. These can lead to the late onset FGRs. Fetal causes like aneuploidies, chromosomal abnormalities, infection, though they cause early onset IUGR, and placental causes like placental infarction, they can lead to IUGR. Apla syndrome.
One thing I want to ask you, if a patient has had a subchorionic hemorrhage in her first trimester, right? Now this patient comes to you in the third trimester. Are there chances of her having, more chances of her having late onset IUGR or not? She's had a subchorionic hemorrhage in her first trimester. Now she has come to you in the third trimester. Don't you think there'll be increased chances of having late IUGR? Because that portion of the placenta which was separated is gone, right? So effectively, that is a placental cause, and that we as gynecologists should remember that if there is a patient who has carried on, there's been a subchorionic hemorrhage and she has carried on, then we need to monitor that patient also for late IUGR, right?
Yeah, ma'am.
So there is compensation and then there is decompensation. Initially, there is compensation when the blood supply through the partial placenta is good enough. That is the mechanism. We did one program where Dr. Vivek Krishnan spoke about the placenta in detail. So what we are saying is that that much of placenta is good enough. And then it becomes not good enough and the baby starts lagging behind. And then once it starts lagging behind, then the Doppler changes will also occur. So this is the sequence that we have. And Dr. Shaili, would you read it out, please? Just the sequence one by one, so
Yeah.
everybody remembers.
Initially, there will be a decrease in umbilicus venous volume and liver size. This will lead to abdominal circumference lag, and this will be the first biometric sign of FGR. After that, increased umbilical artery Doppler resistance. And after that, there will be flow redistribution and MCA changes will be there. Middle cerebral artery will have compensatory vasodilatation. After that, there will be onset of reduced amniotic fluid. And if there is further decompensation, then there will be absent end-diastolic flow. And after that, absent end-diastolic flow in umbilical artery. After that, loss of fetal movement and loss of variability in CTG. And if there is further decompensation, then there will be reverse and diastolic flow in umbilical artery. Then there will be ductus venosus changes, absent A wave or reversed A wave. Then biophysical profile or biophysical score will decline. Then we'll get non-reactive NST and we will get late decelerations. And this will finally lead to fetal circulatory collapse and fetal death.
So, Purvi, there is some talk about ductus venosus and the aortic arch for aortic isthmus. So, what do you say about that?
So these are the late Doppler changes. First, we look at the umbilical artery and the MCA.
No, you've
This
done
is the
that.
basic. Yeah, this is the
Yeah.
basic Doppler. Once you have defined that, yes, those are abnormal, then we do an extended Doppler study, which includes the aortic isthmus flow reversal, which is pathological. If it is no reversal, it is normal. And we have ductus venosus abnormality, that is also reversal of the A wave. So according to the classification, if there is aortic isthmus reversal, it is classified as stage 2. And we need to deliver after or at 34 weeks. If ductus venosus pulsatility index is more than 95 centile at 30 weeks. And it is called stage 3. If ductus venosus flow is absent or reversed, then at any point of time, that is beyond 26 or at 26 weeks, if at all, the Doppler becomes abnormal. So the first grading of FGR stage 1 is umbilical artery and MCA. Grade 2 has absent umbilical artery and then starts with aortic isthmus. Stage 3 and 4 has ductus venosus abnormality.
Okay, so what we are saying here is that everybody needs to look at the umbilical, but that does not, unless there is a reversal of flow or absent and diastolic flow, you don't decide mode of delivery by that. Right? So this is a FGR fetus with a normal umbilical artery Doppler and BPS. So what are you going to do with this fetus?
We'll monitor.
It's small, but umbilical artery is normal.
So ma'am, not yet FGR? Is it not yet FGR? Because both the things are written, that's why I asked. Maybe
what you have seen is growth restricted.
Yes,
okay,
not yet.
But
yes,
it's a small baby. Basically, it's a small baby. Now, you have to differentiate whether it is growth restricted or it is constitutionally small.
Right.
Okay, so for that difference, what do?
We do a Doppler.
You do a Doppler. Okay, now that Doppler is normal.
Yes, SGA.
So it becomes an SGA. Simple. You would also look at the parents at both the parents, you know, if the mother is 4 feet 6 inches and she is a BMI of 20, that baby is going to be thin and small.
Yes, so, and obviously dating also we have to see. Sometimes they just come at the 3rd trimester scan, so we need to date them correctly.
Yes, so as Dr. Aparna said, you have to do the correct dating, and if they have any kind of reports, we need to look at those reports. So now this is a small fetus with a normal umbilical artery, but amniotic fluid is less. Are you worried?
Yes. Ma'am, we need to monitor this baby for Doppler changes.
For us gynecologists, I'm asking you, what is a normal maximum vertical pocket? How much is normal? And when would you call it less?
4 to 8 centimeters.
Less than 2 centimeter is abnormal. Single vertical pocket, less than 2 centimeters.
Okay. And so it's 2 to 8 is considered normal. 2 to 8 is considered normal. Now the fluid is less, but the umbilical artery is normal. And the fetus doesn't show anything much. What are you going to do? See, this baby is with you in the 3rd trimester. He has reduced amniotic fluid volume. What do you want an assurance of? Are you going to look at her kidneys and bladder? Matlab the baby's kidneys and bladder?
Definitely.
So that is one thing we need to remember before we label that, no, don't worry. Because late onset anomalies are going to come, and for that we need to see that baby. We need to see the kidneys, we need to see the bladder. If everything looks normal, then you would do surveillance, right? Now, to my gynecologist, my fellow gynecologist, I'm asking you, would you give her L-arginine?
Yes, ma'am. Routinely तो देते ही हैं हम.
कितना देते हैं?
Routinely we give.
How much?
Like one sachet that is around 5 grams, I think, per
3
day.
grams. See,
3
what
grams.
we have to understand is that dehydration itself can cause a low Liker volume.
Yes.
Because it is, so the mother has to be very well hydrated. Supposing she came into your OPD in the morning and you're seeing her in the afternoon, she didn't want to go to the public toilet, so she didn't drink water. Simple. You know, so we need to see that our patient is really well hydrated, see her twice, whether the Liker is consistently small, and then take a call. If a small baby, no anomaly, and Liker is less, then you're going to examine her weekly. Okay? Purvi, I'm asking you, would you wait till 2 centimeters or even 3 you would be alert?
Ma'am, if at all we can do more surveillance, it is always better. As ma'am told, if we can do it, we should do it. But if at all going by definition, oligo is not a part of FGR family. So we will not classify.
No, but this is a small fetus. This is a small fetus. The artery is normal.
The Doppler is normal. Yeah. Obviously, I would want to do more surveillance, ma'am.
Okay. Samir, would you like to add something to that? Dr. Samir?
Hello.
Okay, so, yes, Samir.
Yes,
do you want to add something here?
Dr. Purvi has very rightly said that oligo should not be the only criteria for FGR and should not be the only criteria for termination of pregnancy and delivery. And fetal Doppler is a very important criteria, especially after 36 weeks of gestation. He is very right.
Okay, so here this is the flow chart that if you have a normal umbilical artery, normal biophysical scoring, and normal Dopplers, follow up and deliver at term. Low Liker, monitor weekly. What are you monitoring? The biophysical profile. Biometry 2 weeks, biophysical profile weekly. And if surveillance is normal, then you're going to deliver at term. Now, this is a third situation. Again, a small fetus.
What should be the mode of delivery in these patients with low Liker?
Normal. Induction of labor. See, because as Dr. Purvi said, Dr. Aparna said, and Dr. Samir, all three have said that low Liker is not an indication for cesarean section anymore. It is just an indication for monitoring. Monitor the baby during delivery. Want to add something there, Purvi?
Yes, so these are the fetal indication, ma'am. Obstetric indication are separate. So fetal indication does not. Yes, ma'am. So at any point of time, if we have, fetal distress during the event of the labor, then that is a separate scenario.
That is that if you have cervical dystocia, if there is failed induction of labor, patients get PIH, anything, any obstetric indication, it's a malpresentation, malposition, placenta previa, it could be anything. Any obstetric indications are separate, but considering everything normal, we would proceed to a vaginal delivery or trial of labor. So then this is an FGR fetus, but here now the umbilical artery resistance has increased, but it's not absent flow. The MCA is normal, amniotic fluid is also normal. So now what are you going to do? How often are you going to monitor this baby?
Ma'am,
Monitoring
weekly,
remains, yes.
weekly Doppler should be done to look for any deterioration in the changes, and twice weekly fetal weight monitoring. And if
Recording
the baby
stopped.
doesn't deteriorate and the growth is the baby is growing, then we can deliver her at term.
Okay, so basically what you are saying is that the monitoring remains the same. You're going to see the weight every 2 weeks. You're going to see the Dopplers every week.
Yeah,
right?
ma'am.
And you're also going to see the biophysical profile. You're going to teach her that do the fetal movement count. Because in the third trimester, that is a very big indicator of abnormality, right?
Yes.
And if everything remains normal, she goes to 39 weeks. Is that right, Purvi?
Yes, ma'am, absolutely.
Okay. Now this is another case, raised umbilical artery Doppler, but now cerebral redistribution has occurred and the amniotic fluid volume has decreased. If there is already redistribution in the brain, how long are you going to carry this pregnancy? If you remember what Dr. Aparna showed you, you don't cross 36 weeks. You take to 36 weeks and deliver. Now, how many would try a normal delivery here? Cerebral redistribution has already occurred. There is a raised umbilical artery Doppler. There is decreased fluid. Who's brave? Dr. Ruhi? Would you try a normal delivery? You're muted. Yeah. Bataiye.
Ma'am, I will like to go for a cesarean section in this patient.
Yeah. Shelly?
Ma'am, we can go for PV findings if I feel that she will respond to induction. Then I can go for a short trial of labor in this patient, and cesarean section if required.
So what is a short trial? How short is short? You've put
Ma'am,
in Serviprim. Okay. Now 6 hours are gone by. You put it again, another 6 hours are gone by. Now,
if if fetal heart is okay, but she is not at all progressing with cerebrine, os is not opening, then I won't wait. Then I'll take her up for cesarean.
if she starts having pains, how often will you examine for descent before you decide for delivery?
Ma'am, in early labor, if contractions are adequate in early labor, 4-hourly PV examination can be done with continuous fetal heart rate monitoring. In early labor, ma'am, we can do intermittent also. Continuous, we don't do routinely in our practice. And if she is progressing, then we can wait. Otherwise, if at any point of time I feel she is not progressing, then.
See, my question was basically how short is short? You have, she's having pains, but how long are you going to wait if there is no progress to take her to cesarean?
Ma'am, if 4-hourly she is not progressing, PV is same. Even with,
how many 4 hours are you going to wait? 4 hours, 8 hours, 12 hours? How many hours are you going to wait?
Ma'am, if she is progressing, then we can wait for.
Not progressing. Cervix didn't dilate, it remained posteriorly placed. It became sort of patulous. Are you going to wait or are you going to do a cesarean?
Then, ma'am, I'll go for cesarean section. Like if I put a Serviprime and after 6 hours I don't find any change, then I will go for cesarean section. But if she is improving, os is open or cervix has improved, then I can put another Serviprime like that.
Okay, so this is simple. If Dopplers are normal, deliver at term. If there is redistribution, then consider delivery from 36 weeks. If everything remains normal, just carry her jitna twice a week, monitor karke. But consider delivery. Now this is fetus with absent end diastolic or reverse flow in umbilical arteries. What are you going to do? She's 32 weeks.
Then we have to deliver the baby.
So you'll give steroids?
We'll give steroid cover and magnesium also.
Yes. So you'll give steroids, you'll give magnesium, and you would go ahead and do a cesarean, or you would again try to induce?
Cesarean question for this patient.
Okay. So this is a clear-cut case. You're going ahead and doing a cesarean. Okay. Because these days of extensive litigation, nobody is going to wait till something happens to the baby. The baby gets cerebral palsy, they're sitting on your head. So you need to protect yourself. You also need to protect the mother and the baby. So we work midway, right? So many therapies. What are the different therapies that have been tried? This we've already discussed. Does bed rest have any role?
No, no role.
No role. Now I'll tell you why there is no role. How does FGR actually occur? Because the circulation to the placenta becomes less. If a mother is resting all the time, her circulation becomes even less. So there has to be activity in life so that the mother's circulation is intact, so that the baby's circulation, whatever is there, can go on. So sildenafil, as Dr. Ruhi previously said, is what we are going to do. So this is one paper which everybody should be reading. Management of late onset FGR, pragmatic approach. The conclusion of that paper was that you need appropriate risk stratification to guide. So you should know which are the high risk cases. So you need to expectantly manage low risk, and those that are high risk, you need to give more surveillance, and you need randomized control trials to assess the effect of an evidence-based conservative management for late FGR, because you need to show how it is going to decrease the perinatal morbidity, mortality, and long-term neurodevelopment. So the effect on all that has to be seen. So now I come back to my panelists for one take-home message that they took from today, and then we will be ending the session. We are almost on time. So I would request you, Dr. Ruhi, to start, please.
The very important message was the one and only third trimester scan that should be done at 36 weeks. That is very important. Also, the lighter amount is not the only criteria for doing a cesarean section. It should be monitored along with all other parameters. These were the two very important messages.
Thank you. Thank you so much. Dr. Shelley?
Ma'am, we should have an eye to diagnose late onset FGR. Because many times I think they are missed, and many of them have normal umbilical artery Dopplers. So sometimes it is difficult to diagnose also.
Okay. So we should be taking this symphysiofundal height rather than just palpating and seeing the heart. Dr. Samir?
Yeah, ma'am, as rightly said by Dr. Ruhi and madam also, that we have to be very vigilant about the condition of the fetus as well as the mother. And what mind knows, the eye sees that only. So we have to be vigilant, especially after the 28th week of gestation. And
there is some problem with
I agree with Dr. Aparna madam also that after scan is important. 32-week scan is a very important scan, ma'am. That is the take-home message from my side. 32 and 36.
Kavita Nagar ma'am, you are there. 36. Kavita ma'am, you are still there. Would you like to say something before I ask Dr. Purvi?
See, practically speaking, what exactly we do along with our clinical assessment for FGR fetus, I usually go around at 34-35 weeks for a routine ultrasound. That's what I do in my practice. But today my scenario has changed. It is 36 weeks as per guidelines are going.
Okay. Okay. Purvi, Dr. Purvi, would you like to add one take-home message from your side as a fetal medicine practitioner?
Yes, ma'am. I would like to say 4 points for every patient. First thing, we need to stratify if the patient is low risk, high risk. Second thing, we need to measure the symphysiofundal height. If she is low risk and everything is going great, fine, very good. If at all we can get a scan done at 36 weeks, that is perfect. Secondly, for patients who are high risk, in these patients, we would want to scan again and again. Usually, if at all we have more doubt of FGR. FGR, we need to monitor from the very beginning. We do not want to miss, we do not want a stillbirth. For every obstetrician, fellow radiologist, fellow fetal medicine, I would want to urge them to recognize how to do Dopplers. Doing Doppler is also very important to know how we should know how to do them, the angle correction, the PRF, the color settings. It is actually, as ma'am said, one button away. Once we recognize them, we can do it in our own settings. We can easily counsel, we can easily follow up, and it becomes much easier to manage an FGR if we do it in one setting.
Thank you. Thank you so much. So I think that is all for today. Thank you. Thank you so much from the bottom of my heart. It's all roses and no thorns. Thank you so much. And
thank you, ma'am. Thank you.
Such an informative talk.
So
thank you so much.
Thank you. And with this, I want to thank all the guests, speaker, chairpersons, panelists, audience, and Corona Remedies, who were our academic partners, who have supported us in this endeavor. I thank all of you. We meet next week speaking on adolescent abnormal uterine bleeding. Same time, Wednesday evening, 5 p.m. Hope to see you all there. Thank you, Society of Fetal Medicine, for helping me out in this webinar. Thank you so much. Namaskar.